Hi and welcome to another video for USMLE questions. Today our focus will be obstetrics and gynecology. A 24-year-old woman, gravida 2, para 1 at 33 weeks gestation comes to the clinic for a routine prenatal visit. She reports occasional mild leg swelling by the end of the day and some trouble sleeping due to back discomfort. She denies contractions, bleeding, or leakage of fluid. She has no significant past medical history and has not required any medications during pregnancy. Her vital signs are within normal limits. On examination, the lungs are clear to auscultation and the heart has a soft systolic murmur, best heard at the left sternal border. There is mild pitting edema in the lower extremities. Fundal height measures 28 cm. Laboratory studies, including a complete blood count, metabolic panel, liver function test, and urine analysis, are all within normal limits. Which of the following is the most appropriate next step in management? Now, the key points mentioned in this question are the gestational age of 33 weeks and the fundal height of 28 cm. There is no signs of hypertension, preeclampsia, or infection. There is mild edema and a soft murmur, both of which are common in pregnancy, and all the labs and vitals are within normal limits. This question is testing your understanding of routine antenatal surveillance, specifically how to interpret fundal height measurements and when they require further workup. The options given here are A. Amniocentesis, B. Chest X-ray, C. Echocardiography, D. Fetal ultrasonography, E. 24-hour urine collection. The correct option here would be D, and that is because from 20 weeks of gestation, the fundal height, which is measured in centimeter from the pubic symphysis to the uterine fundus, generally corresponds to the gestational age in weeks. And this measurement is used as a screening tool for fetal growth abnormalities between 24 to 36 weeks. It should typically correspond to the gestational age within plus minus 3 centimeter range, and discrepancies beyond this range may warrant further evaluation. Now, the patient in our question is at 33 weeks, but her fundal height is only 28 centimeter. There is a 5 centimeter discrepancy which is outside the normal range. This raises concern for fetal growth restriction, and the next appropriate step is a fetal ultrasound to evaluate the fetal size, growth, amniotic fluid volume, and placental function. There is one important point here I would like to add, and that is in some sources and textbooks, you may find that a deviation of plus minus 2 centimeter is considered acceptable. So this depends on the specific academic source which you are using. Let's have a look at why the other options are incorrect. Option A, amniocentesis, is incorrect because it is an invasive procedure typically used between 15 to 20 weeks of gestation for genetic evaluation, neural tube defects, or some specific concerns. It is not the first line for assessing fundal height discrepancies or suspected growth restriction in the third trimester. And option B is incorrect because this patient has no respiratory symptoms, chest pain, or abnormal lung exam. Therefore, there is no clinical indication for a chest X-ray, and radiation exposure should also be minimized during pregnancy. And option C is incorrect because a soft systolic murmur heard at the left sternal border is a physiologic flow murmur in pregnancy due to the increased blood flow. In the absence of other signs of cardiac disease such as dyspnea, fatigue, syncope, and cyanosis, echocardiography is not needed. And option E is incorrect because a 24-hour urine collection test is used to evaluate proteinuria, especially when preeclampsia is suspected. However, this patient has a normal blood pressure and normal liver function test and a normal urine analysis, making preeclampsia unlikely. Additionally, the mild ankle swelling is also common in pregnancy and not a concern on its own. A 22-year-old woman, gravida 1, para 0, at 38 weeks gestation, presents with blood-tinged mucus-like vaginal discharge and mild lower abdominal cramping. On examination, the discharge has resolved and her cervix is 3 cm dilated and 70% effaced. Maternal vital signs are normal and fetal heart rate is 145 beats per minute with no signs of distress. What is the most likely diagnosis? Now, there are 5 key clues to focus on this question. Number 1, 38 weeks gestation. This is almost a term pregnancy, so we should consider normal events of labor. Number 2, blood-tinged mucus discharge, which is self-limiting. And this suggests there is cervical changes and it's not active bleeding. Number 3, mild lower abdominal cramping. This could be likely due to early uterine contractions or cervical effacement. Number 4, cervical dilation of 3 cm and 70% effacement. These findings indicate that labor is beginning or imminent. And number 5, no fetal distress, as the fetal heart rate is 145 beats per minute. Normal fetal heart rate usually ranges between 110 to 160 beats per minute. The options given here are A, bloody show, B, placenta previa, C, vasa previa, D, placenta accreta, E, placental abruption. The correct option here would be A, as this presentation is classic for a bloody show, which is the passage of blood-tinged cervical mucus as the cervix begins to efface and dilate in preparation for labor. It is a normal and benign finding in late pregnancy, typically occurring as labor approaches. The pink, red-tinged mucus results from small cervical vessel disruption during cervical softening, and it is self-limited and not associated with fetal distress or hemodynamic instability. Let's have a look at why the other options are incorrect. Option B is incorrect because placenta previa presents with painless, often profuse vaginal bleeding in the 3rd trimester due to the placenta covering or being near the cervical os. In this question, the bleeding is mentioned as minor, self-resolving, and associated with cervical dilation, which is not in favor of placenta previa. And option C is incorrect because vasa previa involves fetal blood vessels crossing the membranes near the cervical os. When the membranes rupture, these vessels can tear, leading to fetal bleeding, resulting in bradycardia and fetal distress. It typically presents with painless bleeding and abnormal fetal heart patterns. This patient's reassuring fetal heart rate makes vasa previa highly unlikely. And option D is incorrect because placenta accreta involves abnormal adherence of the placenta to the uterine wall, often diagnosed after delivery when the placenta fails to separate properly and can also lead to massive postpartum hemorrhage. It does not present with vaginal discharge or mild bleeding before labor and is generally not a cause of early labor bleeding. Option E is incorrect because placental abruption is characterized by painful vaginal bleeding, uterine tenderness, and fetal distress. In this question, there is no mention of uterine tenderness, and also the normal fetal heart rate makes the diagnosis of placental abruption highly unlikely.